Welcome, everybody. I'm David Sklar, Senior Advisor and Professor with the College of Health Solutions. And in relation to this talk, I'm also going to continue to have my identity as an emergency physician, and you'll see where that's relevant as we progress. I'd like to thank you all for joining us here today for this Health Talk webinar, and it's brought to you by the College of Health Solutions at ASU. The College of Health Solutions addresses the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These health talks are one way that we serve the community with timely and relevant educational content that also provides continuing education credits at no cost. And now for a few quick housekeeping items. First of all, this session is being recorded and it will be posted on our website, asuhealthtalks.com. After each of our panelists present, I will moderate a Q&A session and please submit your questions using the Q&A feature, not the chat box, because that's what we're going to be using. And I will just say the Q&A is some of the most dynamic and interesting part of the session, so I hope you'll all stay with us and after the lecture part is completed. Finally, you'll receive a brief survey asking for your input about today's webinar. And if you're requesting continuing education credits, this must be completed in order to receive your credit. If you do not apply for CEUs, we still would appreciate your feedback to improve our series. So today's topic is, what's the truth? Understanding statistics and evidence-based medicine. And I want to just give you a little context as to how we came to this topic. Din Chen, who is a newly arrived executive director for our biostats core that we're creating, and I were having a conversation, and I told him as an emergency physician, I was really very confused about what to do when we are resuscitating someone who has a cardiac arrest. And there was literature that suggested that if we were able to resuscitate them, unfortunately, we don't get to really be successful all the time. But when we are successful and someone has had a cardiac arrest and now their heart is going, there was some literature that suggested that we needed to cool them, cool their brain and their body, and that they would have a better outcome. They might survive to get out of the hospital and have a normal life. And there was at least some suggestion that cooling them would work. But then more recently, there's been other literature that said that cooling doesn't work. And I couldn't understand why we had these two very different outcomes. And I read the studies and both of them seemed very valid to me. And so knowing that I had a statistics expert now as a friend, as a new person who had arrived here, I went to Din and he was very eager to help me. And as I'm sure he will tell you later, he's actually here to help all of us as we do our research. And so he's going to talk about some of the things he did to make some sense out of these two very discrepant studies or outcomes of studies. And I hope you'll enjoy them as much as I have. So I'm going to give you a little bit of background on each of the people. So our first speaker is actually going to be Elizabeth Kaiser, who I taught with evidence-based medicine first, right after I got here at ASU. And Elizabeth is a good friend and she does a lot of things here at the college. So she's a lecturer at the College of Health Solutions and also the degree director for our undergraduate program in the science of healthcare delivery. She teaches and mentors students in research methods, biostatistics, process engineering, and public health. And prior to joining ASU, she worked in the public health administration area for local Arizona governments and obtained her doctorate in public health policy and management from the University of Arizona. And then following her, we will have Din Chen, who has extensive experience in biostatistics, clinical trials, public health, and is a fellow of the American Statistical Association. He's also the executive director and professor in biostatistics at the College of Health Solutions. He has more than 200 refereed professional publications and has co-authored or edited 33 books on clinical trial methodology, meta-analysis, causal inference in evidence-based public health research and application. So with that, I'm going to ask Elizabeth to get us started, and I hope you'll all be able to listen and hear her, and then be ready to ask some good questions. So Elizabeth, take it away.
Thank you, Dr. Sklar. So what is true? It's such a good question, and one I struggle with, as many of you do, on almost a daily basis. For much of my professional life, I've lived and worked in rural Arizona, and rural citizens tend to have a greater mistrust of government, agencies, official reports, and academics. The truth, according to these salt of the earth folks, differs often greatly from the scientific truth. I spent a lot of time trying to take what is known by science and present that in a way that will be understandable to lay audiences. However, frankly, there's many times I'm unsuccessful. Recently, a 7th grade teacher said to his class, "Scientists are like toddlers with crayons. Science just keeps changing. When my kids are grown up, the science will be completely different." And I think you probably can sense the tone there. He did not mean that as a compliment. In fact, he sees the evolution of knowledge as a weakness of science, where we scientists see it as a strength. The fallibility of science, the fact that it can be tested, argued, changed, is a feature of the scientific method, not a bug. We have to understand where the lay audience is coming from, though, if we hope to communicate scientific consensus to others. But the 7th grade teacher does have a very good point. Scientific knowledge is evolving, and it's very confusing to many, maybe a majority of Americans. What is known is often unclear or confusing. Just look at our headlines. In 1 week, during the first week of February, I read the following seemingly conflicting headlines. There's 3 of them. The first one was, University of Michigan study, ivermectin doesn't treat COVID, but insurers pay for it anyway. Number 2, ivermectin's potential to treat COVID gets a serious look in Duke University study. And the third one, ivermectin shows antiviral effect against COVID, a Japanese company says. So these 3 articles present the view that ivermectin doesn't work, that it has the potential to work, and that it does work against COVID. And to the lay audience, it appears that somebody doesn't know what they're talking about. When I see these headlines, my takeaway is that we have an open research question where we have not yet reached a scientific consensus. While we see many news reports presenting scientific findings, all findings are not equally compelling. When we talk about rigor in scientific inquiry, we're looking at both statistical considerations as well as the use of gold standard research design. Here are some things we consider when looking at a research study. We're looking at the statistical power of the study. For instance, were there enough participants and data collected for the statistical test to detect a significant result if one exists? We're looking at outcomes or variables being studied. What is the primary outcome? How are the outcomes measured? Were the outcomes measured with reliable and valid tools? What were the methods of data collection? And for instance, survey data is not as rigorous as biological or biometric data. We're looking at how the sample of participants were drawn from a population. Some sampling methods can introduce bias into a study. Was the sample randomly selected from the population, or were participants recruited because they all sought treatment at a particular clinic? Less use of convenient samples and more use of random samples is preferred. When we're looking at the study design, is this a randomized controlled trial, an RTC, where study participants are randomly assigned to either a treatment or a control group, and both the researchers and participants are blinded to the group assignment? If so, that's a double-blind RTC, and it's among the gold standard of evidence. Other types of studies that don't meet that definition are a lower tier of evidence. We're looking at whether the study is confirming the computational findings of a previous study. Is the study obtaining data from a previous study and seeking to reproduce the computational output? In other words, does the study check the math on a previous study? And finally, we're looking at whether a study is replicating a previous study when methods, variables, and procedures are held consistent. Is the study set up to duplicate a previous study using the same methods, variables, and procedures? Does the study confirm or contradict a previous study? So you see, there are many factors we are weighing to help us weigh the evidence. We have more confidence in studies that are rigorous, use gold standard research and statistical methods, or that confirm previous findings. So this is a way to visualize the hierarchy of evidence. As I mentioned, randomized controlled trials that use gold standard methods and blinding are at the top of the pyramid. Above this, we find systematic reviews. This type of inquiry is a study of studies. Like other studies that are There are criteria that make them of the highest quality. A well-designed systematic review defines the type of studies that will be included in the review and those that will be excluded. Researchers then scour the literature to find as many studies as they can to include in a review. A high-level systematic review, such as those found in like the Cochrane Library, present the body of scientific inquiry on a particular research question. Below randomized and non-randomized trials, we see observational studies. These are really common in public health, where researchers may be comparing outcomes between, say, vaccinated and unvaccinated populations or masked versus unmasked populations. And observational studies give us important insights upon which we base policy decisions. They are used in situations where it might not be practical or feasible or ethical to randomize study participants into an experimental and a control group. They're also used extensively by epidemiologists to understand the relationship between an exposure and the development of an outcome. But we have to remember that these type of studies are not at the top of the evidence pyramid. At the lowest level of evidence pyramid is expert opinion. Much misinformation is spread at the level of the expert. When considering the opinion of an expert, it is important to consider whether the expert is relying on high-level evidence. If so, they'll usually talk about the evidence and will cite the large body of scientific knowledge. There's a final type of evidence to discuss, and that's a meta-analysis. The meta-analysis is a systematic review that includes a statistical analysis. Generally, in a meta-analysis, researchers are comparing measures of effect. That's the strength of the association across multiple studies. The Cochrane Library also includes many high-quality meta-analyses. When looking at meta-analysis, you can really get a picture of the scientific consensus on a particular research question. But with that said, it's important to note that there is no end-all, be-all statistical test which reveals the truth with a capital T in every situation. Statistics, when taken together, paint a picture of one part of the whole. The benefit of a meta-analysis is the ability to see more of the whole picture, but there are always limits. Now, a point about statistical significance. Statistical significance, or the p-value, is also a limited measure of the truth. Renowned researchers have criticized the scientific community's heavy reliance on the p-value. It's not an end-all be-all statistic. And even in realizing this, we know that the scientific journals have a publication bias toward publishing significant results and not publishing results without findings of significance. But our heavy reliance on the p-value as a threshold for publication gives the impression that the finding of significance in itself is very important, when it is really only one factor among many to consider when interpreting results from a study. Additionally, p-values cannot be compared across studies in the same way measures of effects can be. And in the end, statistics are about probability and what we're looking for. In order to know the truth with a capital T, are many high-quality studies on the same topic with similar or same results, which point to the high probability of a particular outcome. It's extremely difficult to grasp the truth during a pandemic or any time a new question is under investigation. From a scientific point of view, this is so understandable. It takes time for a study to be designed and funded, conducted, analyzed, written about, and published. Then we need many more than one study to develop the consensus. The lack of a scientific consensus on a particular question can appear to the lay audience as weakness, uncertainty, incompetence, even immaturity. Remember the 7th grade teacher saying, scientists are like toddlers with crayons. In the absence of a consensus, some speakers who are well-meaning will get things wrong. Findings of some early investigations will not be reproducible. Studies will have conflicting findings, and new articles that are written will be later regarded as incorrect. The strength of the evidence is our guide to the truth, and we should always rely on that highest level of evidence available and be willing to stay engaged and on the lookout for the next piece of high-level evidence so we can present that what is known with confidence. Relying on a particular anecdote or case study or an expert will not provide a balanced and informed perspective of the issue. And a final point I want to share, as a first-generation college student, I've often had conversations with my parents and other family members about scientific truths, especially over these past 2 years. Their experiences in trying to wade through information and opinions from people around them provides me with a daily reminder that my education and training provide me with a foundation of understanding that most Americans lack. Not only should we seek the highest level of evidence, but we should also remain compassionate and understanding when we come in contact with others who have been caught up with expert opinions or other less compelling evidence. I'd like to turn the presentation now over to Dr. Chen. And I have outlined how to evaluate the evidence when there is a substantial amount to consider. However, in some situations, the evidence is much more sparse. And Dr. Chen will discuss an example of how to weigh the evidence when the evidence is not clearly in agreement.
Yeah, thank you, Dr. Kaiser, for this wonderful overview of evidence-based research. I'm going to go a little further on evidence-based research to talk about the steps and the procedures conducting evidence-based research using two examples Dr. Skylar mentioned on temperature management for patients with cardiac arrest. When we talk about evidence-based research, we usually start with a research question. So when we talk about research question, usually we say, the research question, the best research question should be quantifiable. So with the quantifiable research question, we formulate or we come out with a primary outcome or secondary outcomes. So with the research questions in mind, of course, the next step is to collect evidence. But of course, evidence should be the best. So in this case, we do study design with randomized controlled trial, like Dr. Kaiser mentioned, and sometimes we also do observational studies. But in any case, when we do study design or on evidence-based research, we have to power our study with appropriate statistical power. And then based on the power, and then we calculate and we determine the specific sample size to be used, meaning the specific number of patients to be used, so we can have a successful study. So with the sample size determined, and then of course, we recruit patients for the study, and we randomize the patients to the treatment group, and then we monitor them, and then we collect data, and we collect evidence. So, and then of course, we analyze the data and analyze the evidence based on the biostatistical models, such as like a t-test, z-test, chi-square test, regressions, or even longitudinal data, or any other advanced statistical method. So with the data analysis, of course, the next step is, we have a research conclusion. With the research conclusion, we make policy recommendation. And then of course, we publish the results. So to illustrate these steps, we're going to use the two study published by the New England Journal of Medicine on temperature management for patients with cardiac arrest. So in this case, we have two studies. I'm going to go through the two studies with the step I just outlined. Of course, for statistical part, I will try to explain as much as possible. The first study the title is Targeted Temperature Management for Cardiac Arrest with Long Shock Rhythm. So the background for this study is nowadays we have a recommendation. The recommendation is the moderate therapeutic hypothermia is currently recommended to improve neurologic outcomes in adults with coma after resuscitated out of hospital cardiac arrest. But this recommendation is very debatable. So when we have a debatable recommendation, of course, the next step is to collect more data, more evidence to confirm this recommendation is in the right direction. So based on that recommendation, based on the debatable recommendation, and then the research question is to assess the effectiveness of the moderate therapeutic hypothermia for patients with cardiac arrest. So with the research question in mind, as I mentioned, the next step is to do study design. So in the study design, usually for medical studies, we use randomized control trial, so RCTs. So in this case, we have an RCT to compare moderate therapeutic hypothermia with the temperature 33 degrees for the first 24 hours, with the targeted recommended the normothermia with a temperature at 37 degrees for 48 hours. For the patients with a coma who have been admitted to ICU, from cardiac arrest with long shockable rhythm. Based on the research question and the study design, we need to have a primary outcome, and of course, we have a secondary outcome for any clinical trial, trials. So the primary outcome here is to looking at the favorable neurologic outcome for the patients. So in this case, when we talk about a favorable neurological outcome, the neurological outcome is assessed at 3 months after randomization. So use a CPC scale range from 1 to 5. 1 means better, with higher score indicate great disability. So if you have a score with 1 or 2, that means you are in relatively better condition. When you come to the 3, 4, 5, that means you have great disability. So the favorable neurologic outcome is defined as a CPC score of 1 and 2. So the primary outcome is to looking at, is to compare these two treatments, the therapeutical hypothermia with the targeted normothermia, while looking at the patients with the favorable neurological outcome. Of course, the secondary outcomes, we have mortality. Patients can die when you do clinical trials, and also the safety, like mechanical ventilation duration, length of stay in ICU and the hospital, infections and the hematology, adverse event. So now, as I mentioned, when we have a research question and then we have a study design in mind, so we need to, and then we have to do a power analysis and a sample size estimation, because, for any study, we want to have a well-powered study so we can confirm the research question, but also the time is limited, right? The time is limited, and then we need to recruit patients. We need to monitor them for so long. So we need to have the right number of patients. So that's why this part, the power analysis and the sample size estimation, is very important for any RCT. So for this data, they aim for 80% power to detect a group difference of 9% points for the primary outcome at a two-sided significance level of 5%. Of course, we come out with some statistical jargon here, but just keep that in mind. If you need the statistics, you come to us. Just keep in mind here is we need to have higher power, meaning higher probability to power this study so we can see the research question to be confirmed. So with this study, they aimed at 80% power. With 80% power with other input, they decided to have 584 patients to be recruited for this study. Usually, after we determine the power, we come out with the research. We come out with research question, and also we have the power calculation sample size determined. And then, of course, the next step is to recruit patients. Of course, when you recruit patients, usually we have this kind of diagram. So the history of the patients with inclusion, exclusion criteria, and finally we come out with a number based on the power analysis, sample size determination, and they will randomize those patients into treatment and control. So in this case, they assessed 2,723 patients from January 26, 2014 to January 12, 2018, 4 years time, with 584 patients from 25 ICUs in France, who are eligible for this study. Of course, every time when you recruit patients, sometimes patients can drop out. So in this case, we started with 584 patients in the randomization, but the final data analysis is 581. So the data from 581 patients were analyzed. So with among these 581, 284 patients are randomized to the hypothermia group, and then 297 patients were randomized into the normothermia group. So with the patient randomized into the clinical trial, and then after the study is done, and then we analyze the data. The first part, of course, is to analyze the primary outcome. The primary outcome here is we want to analyze for the patients alive with the CPC score of 1 or 2 at 3 months, because we want to look at the favorable neurological outcome. So with this primary outcome, in the hypothermia group, we have 29 patients from 284 with the probability of 10.2%, and for the normal thermia group, we have 17 from 297. The probability is 5.7%, and then when we have this kind of data, we come to the statistics. We do z-test, t-test, or some kind of regression. So in this case, the difference between these two is 4.5 percentage points. And then we calculate a 95% confidence interval, which is 0.1 to 8.9. So when we read this kind of statistic conclusion is, when you look at the confidence interval, you look at the confidence interval from the left to the right to see whether they cover 0. So in this case, it's from 0.1 to 8.9. So in this case, we say this is statistically significant with a p-value at 0.04. So in this case, if we look at the patients with a CPC score of 1 or 2 at 3 months, the hypothermia group actually is favorable compared with the normothermia group. And then, of course, after we analyze the primary outcome, we do further analysis for secondary outcome. So the secondary outcome for this study is, the mortality in 3 months. So in this study, we have 231 patients died in hypothermia and 247 in normothermia. So the risk or the probability is 81.3% with 83.2% difference between these two groups. But of course, we come to the 95% confidence interval again. So in this case, the 95% confidence interval is from -8 to 4.2. This confidence interval covers 0. That means statistically, the mortality is not different. Also, we look at the incidence of overall adverse events and other secondary outcome. They did not differ significantly between group 2. So general conclusion for the first study is the moderate therapeutic hypothermia leaded to a higher percentage of patients with a favorable neurologic outcome at 3 months than the targeted normothermia group. The second study is also aimed at determining the hypothermia with the normothermia for patients with a cardiac arrest. The research question, of course, follows from the previous one. So the research question is to assess, or is to use RCT, randomized controlled trial, to assess the benefit and harmful effects between hypothermia and the normothermia for patients after cardiac arrest at 6 months. Just be clear. So the second study is aimed at the outcome at 6 months compared with the first study with the outcome at 3 months. So this is a difference. And also in the second study, we have a primary outcome, which is different from the first study. The primary outcome is talking about the death at 6 months. And then the mortality for the first study is the secondary outcome. And then for the second study, the secondary outcome is looking at the functional outcome, the neurological outcome at 6 months, assessed by a modified Rankin scale from 0 to 6. In this case, the 0 meaning no symptom, 6 mean death. That means when as the number increase, and then we have a severe situation. And then, of course, we look at the subgroups too. The sample size determination, as I mentioned, we need to always do for randomized control trial. So for this one, we power at 90% instead of 80% in the previous study. So with higher power, you need more patients because we have a higher probability, the higher power detect the difference. So in this case, what we have is we aimed to study at 90% power. We need 1,862 patients, but because of they allow for loss of follow-up and withdrawal, so the sample size of 1,900 was chosen. So in this case, in the second study, they recruited 1,900 patients randomized, and then of course we have some patients withdraw, and then the total sample size for the analysis is 1,850. So with this 1,850 patients for the primary outcome with the death, in the hypothermia group, we have 465 patients from 925 with a risk probability of 50%. And then the normothermia group, we have death from 446 from 925 with the risk about 28%. So in this case, we look at the probability, look at the confidence interval, or look at the risk ratio. You can see the 50% and 48%, the risk ratio is around 1. So statistically, they are not really significant. And of course, we can also do further analysis in the subgroup analysis. In this case, this is a great picture. So usually we look at the first situation is the whole group, and then we break them by sex, age, and other conditions. You can see, look at the confidence interval. If the confidence interval covers 1, that means they are not different because we talk about the death rate. So you can see in all the subgroup analysis, the confidence interval covers 1, that means they are not statistically significant. The same thing for the neurologic outcome. So for the neurologic outcome, if we're looking at a scale for the 4 to 6, meaning the severe condition, the patient with severe condition, so you can see, so both hypothermia, normothermia, and then the confidence interval actually covers 1, 2. That means in this situation, so they are not statistically significant. Okay, the conclusion definitely for the second study is that the targeted hypothermia did not lead to a lower incidence of death by 6 months than the targeted normothermia. So this seems a little conflict if we put these two studies together. The first study actually is aimed for the neurologic outcome with the favorable neurologic outcome as the primary outcome. So the hypothermia actually is doing better. But if we look at the death at 6 months as in the second study, we don't see any difference. But keep that in mind, these two studies are different studies, even when we're talking about the hypothermia to the normothermia. So the targeted primary outcome is very different. And also, if you look at the death rate at the 3 months and the mortality rate and the 6 months, they don't have any difference. And also for other secondary outcomes, all the adverse events did not differ significant between groups. So in summary, the first study, both studies are RCT. The first study, we powered the study at 80% power, and then we come out with a sample size 584. But for the second study, we powered the study at 90% probability, and then we have a bigger study with 1,852 patients. The first study on 6 months, the second study on, the first study on 3 months, the second study on 6 months. A mortality rise, so they don't really have a difference. But for the functional outcome, the first study confirmed for the hypothermia, we have a higher percentage of patients with a favorable neural outcome. So meaning for the patient with less severity, this one actually the hypothermia is doing better. But for the second study, if for the patients with moderately severe disability or worse, with a scale at 3, 4, 5, we don't see any difference. Thank you. So if you have any questions, feel free to ask.
Great. Well, thank you both. That was fantastic. And I will tell you that Dr. Chen really helped me to understand whether or not we should be using hypothermia. And my conclusion was that it really does not, it's not going to help, unfortunately, our patients who have cardiac arrest. And so far, other studies have sort of confirmed that same conclusion, although we do try to avoid people from getting hot. So in other words, we don't want the temperature to go up, but cooling, unfortunately, does not seem to be helpful. And that's a very expensive and time-consuming effort to do that. So I was very appreciative that Dr. Chen helped me with that. So the first question, as you think about your questions, the audience here, I'm going to ask our panelists to answer a few questions that I had thought about. So the first one is, with COVID, we've had so much new information, so many new studies, and it's really very confusing to other either physicians, nurses, other health professionals, as well as to the public and to families. And so the first question I'd like to ask you about is this issue of vaccination of children. And I know that Dr. Kaiser has some young children, so I'm sure she's had to think about it both from a personal perspective as well as from a scientific perspective. And I'm wondering if you maybe could help us understand how you made decisions about your own children, whether to vaccinate them or not. How did you look at this confusing data? And of course, anybody who has a child under the age of 5 is going to be struggling with that same data or different types of data, but the same issues about vaccinating their children who are under the age of 5. So Dr. Kaiser, can you help us with your background in evidence-based medicine to look at this problem, this question?
So a couple of things about our context is that my children attended a school that was not masking at all. Like hardly anybody was wearing a mask in the school. So I knew that there was a risk for transmission in the environment. But when I looked at the evidence, of course, I want to look at the papers that are published, but I also want to know what is the highest level of evidence that the FDA is considering and who are the people that are considering that. I always want to know who are the experts that are making the decisions and looking, what data are they looking at? And so I actually found Dr. Offit, which I don't know him personally, but I found that he's on the FDA commission to approve the drugs, and he has a lot of media appearances and things. He's a pediatrician and he's an expert in vaccines and virology. And so I kind of, on YouTube, looked for different appearances that he had made, looked at the dates of the appearances as it got closer to the vaccine being released or approved, getting emergency authorization approval. And I wanted to hear what he was saying about the potential for this vaccine. And he said he would recommend this vaccine for his children, so that's somebody who's looking at the evidence before it's even released to the public. So I'm trying to find that kind of an expert, the expert that's really familiar with the evidence, and then of course look at the evidence myself and consider my context where my children are probably at higher risk because the environment that they're in are, nobody's masking at all. So those are the kinds of decisions I looked at or things I've considered.
Yeah, thank you. Yeah, you really have to take into effect the context of your own question. And I think that's very helpful. So we have a few questions here on the Q&A. So one of them, and I'll ask both of you to think about this. This is from Randall Barron. Can you elaborate on the publication bias and how the effects of quality of evidence is affected by that, particularly in less researched topics? So could you again talk a little bit about publication bias, how that affects the quality of evidence?
I can talk some on this part. So now, of course, nowadays this is a really good. This is a really right-on question, because nowadays when we're looking for evidence, the best evidence will be published, and then most significant conclusion will be published. Does not mean, some studies actually not published are not important. Some of the studies actually are very important, but not published. So the publication bias is extremely important. It's extremely critical in all the statistical analysis. I do meta-analysis. So whenever I do meta-analysis, I try to address the publication bias issue with a statistical test, and then to see whether we have a publication bias. If we identify the publication bias, we adjust the results. So with the developed methods. So that's the typical way to do when you would do meta-analysis.
Good, thank you. So we have some more questions here. Now, this is directed to Dr. Kaiser. And so the question is, we had these two very interesting studies that Dr. Chen described. How can we convey the messages coming out of these studies to lay people? How can we put it into a context that a typical layperson would understand, because they're kind of complex? In other words, could media learn to distinguish between the two studies systematically and scientifically? Because at this point, there seems to be so much misinformation out there. I think either one of you can answer that one if possible.
I would just say yes. I think that media persons who are investigating science should have a firm understanding of how to evaluate the literature. And there are some writers who might just look at a study, any study, to be equally valid or have equal conclusions. Like, there's findings, so I'm going to report it in this, all findings the same way. And that's the danger of kind of looking at the headlines for conclusions, or when you see that there are findings. The study found something. Well, that's fine, but there has to be something about the study. What type of study was it? All these different questions that I raised. And so a good science reporter will actually understand that, and we'll talk about the strength of the evidence, that this was a very compelling study, or this was a study that reproduced a previous study, or it was a review of studies or something like that, where they're talking about the scientific consensus. This builds on a scientific consensus. Or they might say this is an exploratory study. This is a first study into this area. And so they can kind of contextualize evidence for the lay audience, like just by saying something along those lines. This is a first study, or this is a very well-researched topic. It isn't, with science, again, it's about probability. So it's not all or nothing. There isn't, science is evolving, and the research questions, in order for us to have a consensus on a particular topic, we have to have many studies that had the same research question. And the research question, like in this situation, they vary. The research questions were a little bit different. The primary outcomes were a little bit different. So the findings are related to the research question. What we hope for when we're evaluating is we have many studies with the exact same research question, and they were all done in a very gold standard way. So
yeah,
yes.
That's an excellent point and I think Dr. Chen made that point too, that you really have to look at the differences in terms of the study design, how many people, and things like that may differ between them, as well as the primary and secondary outcomes. So I think that's absolutely correct. Now, one of the questions here is also, how have these studies impacted medical practice in clinical settings? This is from Emily Lowell. Sometimes it feels like we're just stuck in our ivory towers without any real life impact. And I will tell you, as a practicing emergency physician, that those studies that Dr. Chen talked about really do have an impact, because when I take care of someone who is brought to me in the emergency department who's had a cardiac arrest, if I believe the first study, I'm going to try to figure out how to cool that person. And in fact, we did that after that article was published. We started to cool a lot of the people who were in a coma, who we had resuscitated. And then the other studies came out later that showed that really wasn't improving outcomes, and people were dying at the same rate. And so we sort of have stopped doing it. And so it really has affected the clinical practice. And I think when you have studies that have such an enormous impact, particularly on neurological outcomes, no one wants to keep people alive who are going to turn into what we would call vegetables or who have no good neurological outcome. So we're always really looking for studies that will help improve that. And the first study seemed to look like it would do that, but then the other studies that Dr. Chen talked about really showed the opposite. And so we've sort of now kind of stopped doing that. There's another question here for Dr. Chen, and I don't know if he can answer it, but it says, it looks like both studies agreed on non-significant difference in mortality of the two conditions, but the mortality rates were different across the studies. In the first study, the mortality at 3 months was around 80% for both groups, while in the second study was about 50% at 6 months. Does this mean that they examined two populations that differ greatly in terms of the severity of their conditions? So
Yeah.
Dr. Chen, any response to that? This was from Francisco Asiai.
Yeah, so these are two different studies. So the population actually are very different, and also the locations are also different too. So, so it's hard to say why the first study we have a higher mortality rate. But another thing, look at this one is the first study will only have a small population, but small sample size at 500. The second one will have more than like 1,900 patients. So the second one actually should be more accurate compared with the first one.
Yeah, so I think that's a good point that the two studies, looking at that mortality is different, which would suggest that one group was probably sicker than the other, or maybe they died at different times before the study started. It's hard to know why that is, but I think that's a very good observation.
It is.
Okay. Now, actually, this next question, and I'll just ask. So, Dr. Chen, there's a question about significant p-values, and there's a lot of question about how important, why do we use, for example, 5% as a p-value? And is that, we do have some studies that use 0.01, others 0.05. Can you say a word about the p-value and why we use the one of 0.05? Yeah,
so now this is long history, right? Long history when the statistic significance testing developed, the 5% in the beginning, when we talk about statistics, we talk about field study, like in the field study. So at that time, with a lot of study, especially on that time, is about a field study on grapes, like on grape study, compare different type of studies. So at that time, I think the industry in the wine production, they think, okay, this 5% actually works perfect. But of course, right now is after like 100 or 200 years of development, because right now is we collect so many, so we conducted so many statistical studies, and also we collect so many data from different study, different field, like a different scientific field, we're thinking differently. So in clinical trial, we still aim for 5%, but for some field, for example, more like observational studies, or even in psychology, social studies, people trying to relax from 5% to 10%. So, and also because of this movement, the American Statistical Association, actually we had a long discussion on the 5% or 6%, the 5% or 10%. So 5% is still the p-value to be used, but of course, depending on your field, depending on your study. So somewhere use 10%, somewhere, but 5% is still the standard.
And I've heard that some people even are recommending that we go lower because of the problem of non-reproducibility that Elizabeth brought up. Yes. That we have so many studies that just make it over the 0.05, make it to 0.4, 0.04 or something, that if we went to 0.01, maybe we wouldn't have this problem of non-reproducibility as much. What do you think about that? Would that make more sense?
Yeah, I totally agree with that. Actually, every time when I do statistical consultation with like a biopharmaceutical company, because for them, every failed study costs them too much.
Yeah.
So when I do power analysis for them, I always say we need to power the study at 1% instead of just 5%. Of course, it's hard to recruit many patients, but in the medical field, if you fail a study, meaning a new drug can come out, that means you lose too much money in that industry. So nowadays we have so many studies going on. I think 1% would be a good direction to go.
Well, that's good. Elizabeth, any thoughts about that?
No, I'm just going to leave it. I think that's.
Yeah, well, it's a controversial issue, and yeah, there is a problem about non-reproducibility. And of course, another problem, of course, is in research. Even after you have a very significant finding, it takes a certain number of years before those findings are applied in populations. So there are delays, and some people estimate it could be 16 years, 18 years, 15 years, but it takes a while before there's a diffusion of a new innovation that comes out in research. And any thoughts about that? Because clearly, if we could bring things into the population that were effective, we could actually cure more people of disease, but instead it takes quite a while for that to happen.
I think that's an excellent point. I mean, it's incumbent on professionals to stay current with their publications and staying educated about what's coming out, the newest studies that are out in their field. But then on all of us as community health educators and so forth to try to distill that information to the lay audience. And I think,
right,
if you can find local leaders that are trusted and you can explain scientific findings so that some of this messaging is coming from people in the community that are already trusted, I think that that's more effective than an academic saying, this is the way that it is.
well,
this is what we know today.
Is about trust. It's so important, and unfortunately, we've had an erosion of trust in the last few years between the public and experts, medical experts, and we really do need to rebuild that. And I'm hoping that with Dr. Chen and his team that we'll be able to create better studies. And Din, do you want to talk a little bit about your new role and your team and what you're here to do?
Yeah, great. And I came here last October, and then for a health study at the CHS, we know we need to have we do a lot of studies. So we need to analyze the data, and then the biostatistic is a key role. So I come here. We like to build a biostatistic group, especially we are going to build a biostatistic graduate degree in master's, and the PhD master's will be in 2024, open for recruitment, and then PhD in 2025. But that's one side of the program. But another side is we do have a biostatistical core. The biostatistical core here is established at the CHS, and then we're open for collaboration, and then we're open for collaboration. We're open to help anyone with research. So if you want to design a study, if you want to do data management, if you want to do data analysis, if you want to write the publications, we have a pipeline to help you out. So feel free to reach us.
Yeah, I think that's wonderful, because that often is the barrier for people with a great idea. They don't have enough statistical help or support, because most of us are just not as fluent with the mathematics of statistics as we probably should be. I think this has been a very excellent discussion, and I also want to encourage any of you who are thinking of going into this field. It's a wide open field as far as jobs go. There are lots of job opportunities, because the need is a growing need for us to have educated statisticians that can help with various kinds of research. So thank you to our speakers who have presented today. and also the presentations of the research that they gave that I think will help us to improve our clinical care. One of those questions that was asked today was, how do we make sure that what we're talking about really is clinically relevant? And part of it is using the methodology analysis that Din talked about, so that we can really compare various studies and come to a valid conclusion. So I encourage everyone who's on today's Health Talks to use what you've heard today. And if you have any questions, I know that Dr. Kaiser and Dr. Chen would probably be happy to interact with you via email, and or I'm sure that if you happen to take one of their classes, it would be a wonderful opportunity to interact with them. So with that, I'm going to close, and I hope people enjoyed this. A little bit different from our usual health talk. We did delve a little bit deeper into some areas that we don't usually do, but I hope everyone enjoyed it, and hope you'll join us again in another month. Thank you all very much.
Thank you.
Yes, the next health talk is March 17 at noon, and that one's actually going to be about telehealth, I believe.